Good morning, everyone. Hi, hello, and welcome to the CLL Society's webinar series, Living Well with CLL. I'm Dr. Brian Kaufman, the Executive Vice President and Chief Medical Officer of the nonprofit CLL Society, and I would like to welcome you to today's webinar, which I think is a really important one on planning ahead, being prepared for the end of life. A couple housekeeping notes, please. Prior to introducing today's speaker, who I'm really excited and proud to have with us, there's a couple items that I do want to mention. All the attendees are muted, but there is a way to ask questions. We ask you to scroll down towards the bottom of the page, direct all questions to the Q&A section displayed at the very bottom of your screen. You can use the mouse and the Q&A box will appear. Feel free to enter questions throughout the webinar. You don't have to wait to the end. And our speaker will answer the questions that have been submitted during the course of the presentation. So some will be answered during the presentation and some will be saved for the end. After the webinar, this is really important to us, you'll receive a short survey. Please provide the CLL Society your feedback as we continue to build this educational resource and plan for future webinars. We need your feedback. It's very important to us because it helps us figure what we've done well, what we could do better. So we really appreciate any help you can give us in that regard. This webinar will be recorded and it will be made available soon to everyone who is on the web, who visits the website. We'll post the presentation slides as well, and you'll be able to find the recording and slides under the tab at the top of the page, support groups and education section of the cllsociety.org website within a week or so after completion of the webinar. Next, I'd like to thank Genentech and Pharmacyclic for making this webinar possible through their grant support. And now I get to the fun part, introducing our speaker. At this time, I'd like to introduce today's speaker, Dr. Ed Ratner. Ed has cared for patients who are elderly, who are frail, who are homebound for more than 3 decades. He's performed research and taught on issues in geriatrics, home care, health informatics, bioethics, and how to best manage end-of-life care. He's a board-certified specialist in geriatric medicine and hospice and palliative care. Dr. Ratner serves as the Associate Director of the Minneapolis Veterans Affairs Geriatric Research Education Clinical Center, and he's also an Associate Professor at the University of Minnesota. So I'm going to pass this over to Dr. Ed Ratner, and we thank him for his time and his expertise on this important subject.
Okay, thank you. So we're going to start with my introduction, and before we put the first question up for me to get to know you, just want to share one other thing is how I became connected to the CLL Society. And I was diagnosed with CLL, I think it's been about 5 years ago. And about a year later, I saw something, I got an email about the CLL Society wanting to form a support group in Minneapolis, and took the opportunity to volunteer to become a facilitator of that group, and did the training with the staff and volunteers of the CLL Society. And we've had such a group now. We're in our second year of that group. So I come from kind of the perspective as a professional, and then kind of more recently in my adult life as a CLL patient also. So I wanted to get to know you. We have somewhere around 80 to 90 people on the webinar today. So the first question I wanted to find out was, what is your CLL specific treatment status? So I have a sense of where you're at. And the choices are watch and wait, without prior treatment. You've had prior treatment, but you're not on anything now because things look good. You have a treatment for remission or cure, and there's a variety of such treatments available. And the ongoing treatment, such as ibrutinib, you take it long term, or that you've chosen to forego possible treatment, regardless of what's gone on in the past due to toxicity or concern that there's not adequate benefit. So we'll open that poll and see kind of where the group is at. So, and this represents probably a cross section of and a reasonable representative sample of people with CLL, with about half of people on a watch and wait status, and that's currently where I'm at. That some people had treatment and are no longer on it. That was 9%. About 5% are undergoing a treatment that has hope for remission or cure. And then 35% have an ongoing treatment such as ibrutinib. So that's helpful to know. So I am glad that we have that kind of cross section, and this talk is really intended for the broad audiences from just diagnosed to people kind of late stage at illness. So can move on. I have a second question, and that's to give me a sense and give you a little time to reflect on how you feel about your disease. How often do you think about CLL disease progression or actually dying related to CLL or other things? So, as I expected, everyone with CLL thinks about this sometime, and in part it's the typical age of patients, individuals with CLL. But we have 15% are feeling having these thoughts a few times per year, such as right before you go to the doctor's appointments for CLL or afterwards. 19% a few times a month. Um, and the largest group is people who think about it at least once a week, but not every day. But 25% of the population, and going back to, if we have the 41% plus 25%, we're over 2/3 of people are thinking about these issues at least once a week. And that is despite that half of the people are on watch and wait. So the issues of end of life care, although um, some people who don't have CLL, some people with CLL said, oh, you need to think about that. And our doctors may say, oh, don't worry about that because you have a good prognosis. It's clear that this audience who signed in for this do think about this. Okay, we'll go on to learning objectives. And when I started working on this, I was thinking in terms of these three key learning objectives. And as you see from the talk, these I hope will achieve, but we're going to kind of talk mostly about the second one, palliative care, not just how to get a consultation, but how to get palliative care, period. But the first is thinking about advanced care planning, and with all that thought, doing something productive with it, thinking about the future in a positive way. And we're going to talk mostly about the what is palliative care and how you can address palliative care issues, and just addressing the concerns or thoughts you have about your disease is part of the palliative care approach. And then we'll spend a little time on what is hospice, and that is kind of important in the general population, but people with cancer of any kind think about that more often. So I have to start with, in case we have some people who are very early in their process of learning about CLL, is the one slide, what is it? And I tried to summarize this in one slide at a non-professional, healthcare professional level. It's most common adult blood cancer. It's basically an accumulation of one type of cell in the blood, a white cell that fights infection in a certain way. And you get it, you could say kind of bad luck, but it's not like you did something that caused this. We were all born with a certain number of mutations. We accumulate more of them with aging, and environmental factors ranging from exposure to Agent Orange in veterans to the radiation that comes from flying and being higher in the sky and closer to where the cosmic rays come from. and there's other environmental factors that we don't fully understand. And there are places in the country and the world that CLL is more or less common, which suggests both the inborn mutations and the environmental factors. Um, Life is limited with CLL, with basically due to two problems. One is that the disease can limit our ability to fight infections, and even at early stages of the disease, there's concerns that we won't build up as much immunity or fight infections as well. And so that's one of the reasons that we're strongly encouraged to get all the types of immunizations that are appropriate for adults to improve our ability to fight infection and build up immunity before the disease progresses. Um, and the second major problem is as the white cells accumulate, other types of cells may be diminished. And one of the key types of blood cells is the red cells, which carry oxygen, and the platelets, which prevent bleeding. And if we have too many white cells and not making enough of those other kinds of cells, one of the ways that people die from CLL is either bleeding or progressive loss of ability to sustain oxygen delivery to the key organs like your brain and your heart. And some demography and epidemiology on CLL. The cancer societies and other sources have summarized data from cancer registries. There are about 20,000 new cases of CLL in the U.S. per year. But it's 8 to 9 times as many people with CLL at any given time, and that ratio of 1 to 9 is growing as people are living longer, and so that there are only about 4,000 deaths from CLL per year. So that's about 2% of the total population of people with CLL. And the latest reports on how long people survive is that in this 5-year survival is a typical cancer predictor, how many people are alive 5 years after diagnosis. And that's currently at 84%, but creeping up. And the current status of the disease is that most of us are going to die of something else. It's not clear kind of about that yet, but with the newer drugs that have become generally available in the last 3 to 5 years, we may live as long as we would have otherwise lived and not died directly of CLL. So with that background, in my medical practice, caring for people with advanced illness and at end of life, I often start my discussion with patients and their families with defining the goals of care. And I've divided all the goals we could possibly have into 3 big categories. And one goal of getting healthcare is to live as long as possible. And that's basically the survival goal. The second is a functional goal. I want to do what I want to do. And whether that's working or skydiving or being with my family, it's doing what I want to do. And that's a goal of healthcare. And sometimes people make choices that I want to do this, even though I know it's not going to make me live as long, but I want to continue to do this or start doing this. And the third category of goals of healthcare is to be comfortable. And that's not just physically comfortable, but emotionally or spiritually comfortable. And the key challenge in advanced illness is when we have to make a choice between these. And so when we when we go to the doctor, we might be emotionally uncomfortable with the anticipation or the news we're going to get at the doctor, but we go because we want to live longer and find out from the doctor what we want to do. So we make that trade-off. And similarly, if somebody breaks their hip and they're told to get out of bed so they can walk again, They say it hurts, but if they don't do it, they won't regain the ability to walk. So we make trade-offs in these cases, but when it comes to deciding what you're going to do about healthcare, you have to recognize that there are trade-offs, and that um, some people say, I just want to live as long as possible. I don't care if I'm in a coma. And I deal with that occasionally, but that is a recognized and acceptable choice that somebody can make. So given kind of that background, a little bit more kind of self-reflection, and to help me kind of know where we're at, the third question is, how important are the non-survival goals to you, both function and comfort? And the choices, can I read them out loud while you vote? Um, that function and comfort are the only things that are important. I'd rather die than sacrifice being able to do what I want to do or be comfortable. Um, Second is very important, but I'll make some sacrifices of function and comfort to live longer. That these are important, but I'd give up a lot of function for or comfort to live longer. And the last, as I said, some people say function and comfort are not important. I do anything to live longer. Okay, so once again, we do have a cross section, and we have 18% of people say that function and comfort are the most important, and that is at in advanced age or advanced illness. That's a common thing. If I talk to most patients in their 80s and 90s, or some even in the hundreds, the vast majority, but not all, patients in those age groups say, I might be not ready to go today, and I'm enjoying my life, but I only enjoy my life because I can do what I want to do, and I don't need to live longer if I'm not going to be able to do what I want to do. But the bulk of people recognize the trade-off, and they'll give something up to in terms of comfort or function to live longer. And some people will give relatively more than others. So that's helpful to kind of see that there is variation, and variation kind of between people and over time, and you may change your mind about these things as you uh, progress in your illness or get older. And one of the common things that I've seen in a variety of illnesses is that people adapt to loss of function and get comfortable with being uncomfortable, and they still want to live longer as long as they can be with their family or be emotionally or spiritually comfortable, and will give up function or live with loss of function. Okay, so going on to the main topic of this talk is palliative care. And as I prepared for this, I pulled up the World Health Organization definition of palliative care. And it's a complex definition, and it's a challenge for people to fully get their head around it. But I think the preparatory comments that and questions we've had kind of prepare you for this. And palliative care is an approach that improves the quality of life of people facing the problem associated with life-threatening illness. And it's done through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And so that's a lot of kind of words, but it basically is saying palliative care is everything about those last two goals. It's not about survival. It's about everything else. And the World Health Organization goes on, and most of the rest of the talk is the titles of the talk of the slides have the additional information from the World Health Organization site about palliative care. And then I've basically annotated these descriptors of palliative care with what it means for CLL. So one of the more obvious aspects of palliative care is the relief of pain and other distressing symptoms. And those symptoms in CLL include pain, fatigue, shortness of breath, fevers, night sweats, insomnia, and a variety of medication side effects that depends on the medication, but there are a variety that can come up with that. And so the idea of for almost all of us who think about issues of our disease progression and potentially dying on a regular basis, um, this is one of the reasons that we think about it is we're afraid of these things. And the idea is that there is an approach that focuses on these things, and that we shouldn't ignore these things just to live longer. And pretty much everybody said they want to have these things addressed, and they're important. They don't necessarily just want to live longer if these things are too severe. So what we want to do is, and we'll talk more about how to get that, we want to push on our healthcare providers and others who might be able to help us to address these things and not consider them insignificant or unimportant, because they all can be addressed if only to normalize and tolerate, even if we can't make them go away. A second thing that palliative care does is, and it may seem kind of incongruent with the definition, but it affirms life uh, and regards dying as a normal process. And so what this means in CLL is that we should expect and demand and ask about our prognosis and get an honest answer. And in our support group and others that I've talked to with CLL, it's not clear that when we go to our CLL clinicians, our oncologists, our primary care providers, that they uh, either know or want to tell us about our prognosis. And they may be more optimistic, or they may not have looked it up and not know, but we're entitled to honesty about this, because we can't consider our life course as normal if we don't know kind of what's coming ahead. And CLL is really more than one disease, and there's been significant efforts into categorizing the disease into high and low risk. But as the new drugs have come out, that those groups in terms of survival have kind of merged some together. And so the real issue about prognosis is where you're at in your course of treatment, and what side effects you're having, and whether you're on first line or second line treatment. But ultimately, the statistics say that that 84% are going to be alive in 5 years, and going forward from now, it might be much higher. We should be told that, and we should know that, and then accept that there is an end to life for all of us, with or without CLL. The second part of affirming life, but I, um, but also recognizing dying is a normal process, is being able to have discussions with our family and healthcare providers about all the treatment options. And that includes foregoing treatments. And it may be, I don't ever want any treatment, but given what treatments are like now, many are well tolerated. So it's relatively rare that somebody would choose to have no treatment specific for CLL. But one barrier that some people kind of face and might decide to forego treatment is based on the cost of some of the treatments that are effective, but might lead to sacrifices for family members or heirs, and leaving children or grandchildren without any money because you chose to take this drug to live some longer, is a choice that we have, and that we have to be able to talk about it. And then the last, and we'll talk more about advanced care planning a little later in the talk, is that we should expect and ask for from palliative care experts, but our whole team, assistance with thinking about the future. Palliative care intends neither to hasten or postpone death. And so that's the focus of palliative. It's not that the person who's receiving palliative care can't want to postpone death, but the palliative care team and efforts are focused on other things. And what this means is that you can combine, and you should combine, efforts to postpone death with palliative care, because there are symptoms and other things we're talking about that need to be addressed in that palliative care approach. Um, at the same time, a CLL would be a highly unusual disease that a person would request assisted suicide where it's legal. And that is because the types of symptoms that one develops with CLL, they can be well managed. And so the pain and suffering that leads to requests for assisted suicide are relatively rare compared to some other disabling or painful diseases. Um, so palliative care um, integrates the psychological and spiritual aspects of patient care. And this is a challenge for most healthcare providers and many healthcare systems, is thinking beyond just the physical aspects and saying, well, you have too many white cells, we can kill some white cells with this drug, and we can give you this medicine for pain. But the uh, the quality of life and the things we care about and function and comfort go beyond that, as well as the attention to these things, psychological and spiritual aspects of care, are known to reduce our need for pain control or other treatments to make us physically comfortable if we address the psychological and spiritual. In CLL, at the simplest level, palliative care is built around empathy. And our healthcare systems, providers, families, friends, um, if we want to receive this part of care, um, is built around having empathy. And that's not sympathy or pity, but that's people recognizing what worth we're concerned about and what pains us, and being supportive of that and trying to address that. Not taking on the pain or simply kind of telling us that's too bad. The worst thing in empathy, and that we probably, many or all of us have encountered, the people who say, oh, well, at least you don't have, or you share that you have CLL, and just kind of for full honesty, I've shared very minimally outside of the CLL community with even family and friends my diagnosis, because people, say things that are unempathetic, such as, well, could be worse. I had a friend who had a worse cancer, or, well, that's, I've heard that that's a good cancer. And those aren't empathetic statements. But you should look for the people and expect people to show empathy. Part of palliative care is mental health, and the worry that or thoughts about our disease progression that most of us are having on a regular basis are uh, are amenable to mental health treatments. And in our support group and personally, I strongly encourage everyone with a new diagnosis of CLL or any similar disease to seek out a mental health provider to talk to, and somebody who can be empathetic and doesn't have a stake in your kind of prognosis and health, and can help you work through the anxieties and other mental health symptoms that you might have, and be supportive for you. And so it doesn't have to be long-term psychotherapy, but at least a few visits with somebody who can be supportive. Support groups and peer support groups like CLL Society has, and there are professionally facilitated support groups that the uh, that some of the other general cancer or the other lymphoma and leukemia support organizations offer. But those are not for everyone, but they are a source of support in psychological and spiritual aspects of care. Um, Taking care of yourself and looking for people who can help you, whether it's a personal trainer or a meditation coach or a yoga instructor, lots of ways to take care of yourself, a dietitian, And you should be encouraged to take care of yourself. Chaplaincy and spirituality issues can be addressed in a variety of ways, but chaplains and every healthcare organization has chaplains, and you don't have to be dying to see a chaplain. And in fact, my daughter is a hospital chaplain whose specific job is to go around to people in the hospital and talk to them about their advanced care planning and healthcare directives. And so it is within scope to ask, even with a CLL diagnosis, with a good prognosis, say, you know, I'm concerned about why God is doing this to me, or how can I maintain my faith? And to see a chaplain who can be empathetic and help with that. And continuing or finding new rituals or religious or spiritual activities is part of palliative care. The support system to be able to live as actively as possible until death. And so what this talk is about preparing for end of life, but as the preparation starts kind of at time of diagnosis, you start thinking about, so when am I going to retire? How long am I going to work? Am I going to cut back? Do I want to wait until I start having symptoms or need treatment, or should I enjoy my retirement and I'll go back to work later? And that's very individual, but the process of palliative care and getting support and help with this, and even your physicians should be able to talk to you or help you think about kind of where you're at and what the future looks like. Promoting recreation and socialization, so just hanging out with other CLL support group members is a form of socialization, but other ways to enjoy your life and not stop enjoying your life. And fatigue or some other side effects of medications can limit or change what you can do or enjoy, but you want to maintain that. And then sometimes you lose function, you lose ability to do things, and rehabilitation is necessary. And that's not inconsistent with having CLL or cancer to say, well, but I used to ride a bike. I want to ride a bike again. I just got out of the hospital. And whatever you're in the hospital for, you might not be feeling as strong. And so saying, I want an exercise program. I want to get back to my former level. The support system it goes beyond our personal needs, physical, emotional, spiritual, to our families. And that's one of the things fairly unique about the concept of palliative care is it consciously thinks about families. And for those of you who are veterans on the call or no veterans, the VA health system fully recognizes this and has a variety of support services and attention to the family members and caregivers of patients. But you start by identifying who are the key family members and making sure your healthcare providers know who those people are and that they're identified as potentially needing assistance in a variety of ways around palliative care, around their feelings and their anxiety about your illness or their adjustments in life they have to make. You should take somebody with you to clinic visits. And it's not only so somebody remembers what the doctor says, but it can reduce their anxiety to be fully included in the discussions. And whoever you trust to make decisions for you, if you can't make it for themselves, you want to include them in your healthcare process. Attending CLL conferences and reading about the disease and going to support groups isn't just for us, and the major organizations that offer CLL conferences explicitly reach out and say, bring your family members. Because the more most family members know, with this disease, the better they can cope, but often the less anxious they are as they realize that there are good treatments as well as good palliative care approaches. Family members might become anxious, depressed, have insomnia, a variety of things. And so reaching out and to mental health providers and getting that kind of help is appropriate for family members, and dealing with the worry about these things so is important for everybody in the family one way or another. And the last is bereavement services, and that's the idea that when we die, and those with CLL, our family members are left behind, and that there is a variety of approaches to supporting family members who have difficulty with the loss, and that process can start before, well before somebody with a disease dies, to help prepare people for that. And advanced care planning is a part of that planning ahead and preparing for that. Palliative care is, I think the message, it should be clear by now that our oncologists can't do this by themselves. It requires a team to meet the needs of patients and their families, and that we should hope for, ask for team members in our CLL oncology practices beyond just the physician. And it might be a social worker, it might be the nurse, it might be a chaplain associated with the cancer program. It might be a dietitian. There are a whole bunch of other people that are available in large healthcare centers and in the community to work with your oncologist. But it isn't necessarily have to come from your healthcare provider where you're getting oncology treatment. And there's lots of other people. We talked about mental health. That's often separate and totally independent than from the standard healthcare systems, the individual practitioners, the small groups that provide mental health services. There's lots of ways you can get that, but what we should do is hope and expect our oncologists to collaborate with those people, whether it's sharing records or at turning points in an illness, a major decision about treatment or hospitalization, is to actually get a variety of team members together and say, we want to have a family meeting including all those people. And then the last two are I don't make it specific to CLL, but the last two kind of comments that the World Health Organization made about palliative care, that it will enhance the quality of life if applied and applied appropriately. But in addition, it can have a positive influence on the course of life, on course of illness. And so basically what's remarkable is palliative care has been shown in a number of studies, and one of the best reported was one of people with advanced lung cancer. And when they added palliative care, people lived longer. And that may seem like, well, how could that be? We're not focusing on living longer. But the attention to the physical, emotional, spiritual aspects of care actually led people to live longer. And that disease, it may have also been because some people chose to forego treatments that were actually going to kill them sooner than the illness itself. And so the process of palliative care and thinking carefully about options and choices led people to say, I'll take the risk of the disease progressing over the risks of the treatment the doctor's offering. And so at some point in CLL, some of us may be faced with those options. And so we may live longer if we think carefully about something other than taking every opportunity to try to live longer. And that the other kind of aspect is that palliative care isn't, and it's often associated with, but it shouldn't be. And this is from a World Health Organization website, so it's not just what I'm making up, but it should be applied early in the course of illness. And I would suggest that we, from the time of diagnosis, and maybe the most important time in CLL care is in those first few months after diagnosis, when you don't fully understand the disease and what's going to happen to you, and your prognosis might be less clear, or you're just starting a treatment for high-risk disease, is that getting palliative care kind of on the radar and working on these physical, spiritual, emotional issues from the beginning should happen. And for those of us who just watch and wait, good prognosis, we often are in those categories, people who still think about our disease progression. And a new diagnosis of cancer should be associated with thinking about palliative care issues from that time of diagnosis, so that we don't spend, as I will admit I did, even though I was well educated and knowledgeable, and I went to my first oncology appointment with a stack of articles that I'd already read, I still kind of was overly anxious about dying in those first few months. And over time, for those of you who are at that point, over time that gets better, but it is got better for me in part because I attended to some of these palliative care things and sought out a support group, sought out a mental health provider, asked for empathy from those that I shared with. So I want to just see where you're all at with your experience with palliative care before I go on to some issues about actually the specifics of end of life care. How well do you think your CLL team, your oncologists and primary care and the CLL providers have been in addressing the palliative care issues? And don't feel bad about being honest, because you may go to a very highly regarded CLL center, but I don't know if there's a correlation or inverse correlation between the quality of the center as thought by the scientific community uh, and and the palliative care issues. What I'm saying is that, and these are things that we should report across support groups and say we can do better, we can ask for better, but a quarter of people said very poorly, and another roughly half said poorly, and only 4% said extremely well in terms of palliative care issues. And that is my sense and experience as a healthcare provider and a CLL patient, that this is not addressed well. And I hope this talk can help you ask for what you want and need. And if you can't get it from your CLL team, say, well, where am I going to get it elsewhere? From my health club, from friends, family, from kind of the non-healthcare center healthcare professionals. Okay, so we have a few, the remainder of the slides. I move on to, so how do we do this? And then some more specifically about hospice and end of life care. So we've commented on some of these already. Is you can bring people with you, family members, loved ones, um, to your appointments with your CLL provider, and they can bring questions, and their needs can be addressed in those appointments in a variety of ways. Um, don't be shy about talking about your symptoms and your feelings. It's not just about your your absolute lymphocyte count and how that's doing, uh, or the other blood counts. These other things are clearly important to us, and we should ask for help. Um, it's not unreasonable to ask for a referral to a palliative care team member. And almost every every hospital now has palliative care teams. A smaller number have outpatient palliative care, but the major CLL centers probably do have outpatient palliative care consultation opportunities where you could see physicians, nurse practitioners, social workers, chaplains who are expert in palliative care, and say, well, when I'm coming, can I get a visit with the palliative care, or can you make a referral and I'll make a follow-up appointment to see somebody from that team? And that's particularly at the inflection points, new diagnosis, change in condition needing to start treatment, a failure of this first treatment or intolerance of a treatment, a change in your life circumstances where you have a change in caregiving or a change in ability to manage your health in the same ways, a development of another serious illness, which is not at all uncommon in people with CLL, is you talking to palliative care team members can help address all these issues. But independent of palliative care, asking for specific referrals to people within the health professions who can address these things. But often you have to build your own palliative care team beyond what the oncology practice or CLL practice offers. And that team can include the right family and friends. So I want to spend a couple minutes on advanced care planning, which is the process of thinking about goals and preferences. So you start with the goals, and we kind of agreed that there's variation in what individuals' goals are at any given point in time and over time, and those goals turn into preferences. Um, a great example in CLL is for some patients they have a choice between chemotherapy and immunotherapy, and one is a kind of one-time, uh, higher risk, more symptomatic, complicated thing, but then you don't need ongoing treatment. Um, and you might be in remission for many years. And so that's related to the goals. Is how much am I going to give up now to not have take these medicines in the future? Advanced care planning um, can be documented in a variety of ways, but one is every adult should have a power of attorney for healthcare, and that's basically a legal document. Doesn't have to be filled out by an attorney, and there's forms you can download online, but it has to be witnessed or notarized. And it simply says, if I can't make decisions for myself, I want X or person or X people to have authority to decide things for me. And that is part of defining our goals and preferences. Who do we trust? Who do we want to make those decisions for us? And our doctors can't take on that role. They want somebody who knows the patient better than they do to advise in the circumstance, whether acutely ill with pneumonia or some problem that we can't think straight and make decisions for ourselves. Who's going to decide? The second healthcare directive is a tool to say what your preferences are. And the third is an order from the doctor related to your healthcare directive saying this is what should be done. And so that's an order from a doctor to emergency medical services. Advanced care planning and the healthcare directive can include funeral planning. Where do you want to be buried? Or what kind of music do you want played at your funeral? You can write all that down. And this whole process is a gift to family members. It reduces the stress and strain and conflict if you do this in advance. In CLL, as I said, if you can't express your preferences, you need some process. It reduces conflict. And in our planning in our documents, we should think about and kind of plan ahead for what are we going to do if we can't decide anymore and our CLL isn't being managed well by the treatments. The CLL treatment is causing too much suffering. Some other illness is even more life-threatening than CLL, or our brains have deteriorated from dementia or stroke or something else, and we're not going to recover. And the question is, if you're on ibrutinib or some other drug that you're taking, very expensive, might have side effects, and should your family or should your doctors ultimately continue those medicines, even if they're not working or they're causing suffering or you're going to die anyways? You're not going to wake up. So telling somebody you have authority and I don't want, if I'm going to die anyways, you don't need to give me that drug anymore, will reduce the stress of trying to make that decision for your family members. Or potentially, if you don't have a documentation, it can end up going to court and being very complicated and painful. In CLL, the end of life care, as I said, most of us are not going to die directly of CLL or infections or bleeding. We're going to die of some other illness. But the anemia and infection are the common mechanism if you are going to die directly of a CLL-related complication. In the end of life circumstances, most people want to stay at home. Not everybody can, not everybody wants to, but we want to be comfortable and we rarely want to be a burden on other people. And so those are common goals. Different people have different, and these can conflict. You say, I want to be at home, but I know that's a burden. So how are we going to balance those? So the choices in CLL can be as stark as saying, I want to go to the hospital and I want this experimental treatment versus I want hospice care. And hospice care is the model to do end of life care with a palliative care approach. Hospice, and kind of wrap it up with kind of what that is it's a philosophy. It's focused on palliative care. It's a program, so there are licensed programs. It's also an insurance benefit, and so there's if you look in your insurance manual, it says you have an insurance benefit for hospice, and virtually everybody does have that. It's a whole team to provide the palliative care. We talked about it, the team members. Hospice isn't just a place. It can be a building that's dedicated hospice, but most hospice is delivered at people's individual homes or nursing facilities. There are hospitals that offer hospice in their hospitals too. Fully covered. When I say fully, there are no copays for pretty much anybody in hospice. So it's a great deal. It like palliative care, it supports family and patients. And enrolling in hospice is one of these very low risk kind of things because you can sign up and you can drop out. You can sign up and then change to a different hospice. So it's a really low risk, low commitment process. And the CLL Society has put up a web page within the site that gives a lot more detail about hospice care. It's not suggested by doctors in a timely manner. Most people are enrolled in hospice just for days or maybe a couple weeks, but you're eligible as soon as your life expectancy is 6 months. And that doesn't mean you have to die in 6 months and then you lose out. You can't have it anymore. But the insurance benefit is based on 6 month life expectancy. And this then, so within CLL, should be thinking about a hospice when you have another illness besides CLL that's terminal. That may seem obvious, but also when your CLL has reached a point where you're not leaving home easily, and that's not going to get better. So you're not in a rehabilitation mode, but the disease has progressed. Your shortness of breath, I want to go back. Your shortness of breath or your fatigue is so great that you're not leaving home anymore. And that may not be exactly at 6 months, but it's worth at least talking to a hospice program about. So, what am I going to do now? If you're not tolerating the treatments for CLL anymore, and you've been through a number, one or more of them, that may be a point where your prognosis is eligible for hospice. And if your only options are CLL are experimental, then the option is say, no, I don't want that. I'll take what's behind the curtain, which is hospice. How do you get hospice? Your providers can refer you, but uniquely Medicare and most people with CLL and most people dying of CLL, even greater percentage are on Medicare. It is the only Medicare service that you can just call up a hospice program and say, I want hospice. Can you come and assess me to see if I'm eligible? And they can do the paperwork to kind of enroll you without a doctor. So if your oncologist says, no, I don't think you're appropriate for hospice, but you think you are, just call the hospice program directly and say, can you come and assess me? And they'll do that assessment and tell you, well, not now, maybe later, or yes, we'll try it. And if you stay really well for the next couple months, we'll discharge you and we can readmit you later. So it's a pretty low risk kind of thing. So in summary, so we have a few minutes for questions. CLL may cause worry about end-of-life issues. It's appropriate from diagnosis through bereavement. You should ask for it. Advanced care planning should be part of everybody's CLL care plan, and hospice is appropriate at the end of life. Okay, so I'm looking at the questions that are posted. First is, do deaths from CLL include deaths from infection? The death certificate may list pneumonia, but it should then say due to CLL. But it depends on how the doctor fills out the death certificate. but that is the process. If you're dying of infection and you have CLL, it's probably kind of related to the CLL. Second question is, how do we engage palliative care professionals? And as I said, you can ask your healthcare providers for referral. You can look on the website for your hospital that you're most affiliated with and call them, and self-refer to an outpatient appointment. If you're in the hospital, you can ask the doctors and nurses, can I have a palliative care consult? It'd be interesting to know how many people go to a CLL specialist. My doctor only sees CLL patients. There are a handful of centers and clinics and doctors who just do CLL. And those doctors tend to be more interested in it. That doesn't mean that they're interested in palliative aspects of CLL or anything. And so it's kind of recognizing that one doesn't equal the other. And the last and maybe kind of most common question about all this, so can I keep taking the drugs if I enroll in hospice? And the challenge, you can take any drug not related to CLL, and the hospice doesn't pay for it, and your other insurance you have continues to cover it. And so that's all independent. Hospice is, if you enroll for CLL, then they are just responsible for CLL-related treatment. The challenge is, if you want to continue ibrutinib, you can't also enroll in hospice. And some of that is simply a function of it's too expensive for the hospice to pay for it, but they have to pay for it. The hospices are paid like about $200 a day to take care of you. And if the drugs alone add up to more than that, then they can't enroll you, even if your prognosis is really poor. But they could enroll you for a different disease. If you're dying of lung cancer, then you can enroll for that and you can continue your ibrutinib on whatever insurance. Are there guidelines to choosing a hospice care provider? The CLL website has some links to resources to help you decide how to pick. And then there are a variety of websites, including Medicare.gov, that help you find the list of all the ones in your community. How do we plug in clinical risk assessment terms such as overall survival into planning? And basically, if you want to plan your life, you want some idea how long am I going to live? And overall survival is a measure of that. Survival to treatment is another kind of term that's used. And so how long am I going to, if you're on watch and wait, how long until I might need a treatment? And that is something that there isn't great data on populations for, but your individual CLL specialist can help you understand kind of both of those kinds of things. And as I said, overall survival, most of us are going to live as long as we would live based on our age and other illnesses, but that's not everybody. And let's see, hospice is not the same in every state. Florida seems to treat hospice as only available for the last week or so. Well, that's a vicious cycle. If you think it's only for the last week or so, and the doctors think it's for the last week or so, then it is. The hospice programs don't want it to be, and they want to enroll people sooner because they're paid the same per day, and the first couple days and the last few days of hospice cost the agency a lot more. So they want at least a month or 2 months of hospice care for people enroll. And CLL is one of those diseases where there probably is a couple months from the time that you realize this isn't working anymore to when you actually die, and versus waiting until you're hospitalized and are can't breathe and the machines have to be disconnected. So do think about this earlier, and it nationally, this is a problem where the oncologists don't refer at an appropriate time, and so people die after just enrolling it for a few days. And somebody asked, can we kind of look into this better, how palliative care needs are being addressed? And I think that's a project. We have a end of life or hospice committee of the CLL Society. And I think the data we got from this poll in this sample suggests we need to look into this better. So I want to thank you. We want to wrap it up on time. And please feel free to share this with your friends, family, CLL support group members, and others. And this will be posted in the near future.
And I wanted to thank Dr. Ratner for this, really informative and well-organized, thoughtful kind of approach for this important information. And we have, and maybe Dr. Ratner, you could just comment a little bit on the resources that you were part of a committee that put some resources up on the CLL Society website. I wonder if you could just briefly comment on that. But
yeah,
there are lots of questions that came in, and we appreciate that, and this will be available for you to look at within a week. Dr. Ratner, you just want to kind of wrap up stuff by mentioning what's available on the website for people?
It's kind of about a third of the way through the slide set. There was a link, and you can go back to this presentation or kind of search around on the website. But the committee group of us put together a variety of resources about palliative care and end of life care, and a lot of it is links to other places you can get more information. In addition, for those who attend a CLL support group, the facilitator's guide has some specific materials to help facilitators address these issues in your support group. And this should be a topic that at least once or twice a year, support group should put some time aside to address the palliative care as specific issues beyond just being in a support group and learning about CLL.
Yeah, we have documents that you can download that can help you organize things for your family and stuff in terms of where are the documents, helps with advanced directives, all that kind of stuff. So, please check that out on the website. And thank you again, Dr. Ratner, and thanks everyone for attending, and thanks for the great questions. And I think with that, we can wrap this up.